بنبدأ المحاضرة Sorethroat. أنا الدكتور أحمد الدجوي، أستاذ أنف وأذن جامعة المنصورة. الهدف من المحاضرة ال ILO's Internal Learning Objectives. نعرف الأول هو إيه الفارنكس، ونعرف السورثروت، ونقول إيه الحاجات اللي بتسبب السورثروت ونفرق بينهم إزاي. وفي نفس الوقت بناخد سكيلز من أثناء الدياجنوزس عشان نعرف نشخص لما تجيلنا حالة بعد كده، ونشوف الحالات اللي ممكن تسبب السورثروت. وفي الآخر بنعمل مانجمنت للسورثروت، يعني مش كل حالة هتبقى نفس العلاج، هيبقى في حالات لها سبيشال انترست. طب ايه السكيلز اللي احنا هنكتسبها اثناء التشخيص؟ غالبا نمرة واحد علشان نفحص الفارنكس بنمسك تانج ديبريسور وبنفحص بيه العيان. التانج ديبريسور عشان نمسكه صح بيبقى له مواصفات معينة هنقولها. طيب ايه علاقة السورثروت بالروماتيك فيفر؟ ده سؤال شهير بنتسأله، اللي عنده سورثروت واللي عنده تونسولايتس واللي عنده فارنجايتس، كل دول تقريبا تحت مسمى واحد. ايه علاقته بالروماتيك فيفر؟ ايه علاقة استئصال اللوزتين بالروماتيك فيفر؟ كل ده هنقوله في المحاضرة. تاني حاجة واحنا بنفحص عشان نقول في كونجيشن او في ريدنس او في حاجة في الميوكس ممبرين، لازم نعرف النورمال ميوكس ممبرين الاول. النورمال ميوكس ممبرين اوف ذا فارنكس اند اورال كافيتي، وبالمرة نعرف النورمال ميوكس ممبرين اوف ذا نوز. طيب بين اثناء التشخيص بيجي لنا حاجه اسمها برودروما. يعني ايه برودروما؟ يعني ممكن السورثروت ده يبقى مقدمه لحاجه تانية، فما نفضلش نقول دي فارنجايتس ونعالج الفارنجايتس، لا، انه ممكن بعد يومين ثلاثه يحصل راش، بعد يومين ثلاثه الاقي الدنيا اختلفت. فلازم ابقى عارف ان السورثروت may be one of the prodromas. لما ببدأ في التشخيص ساعات بحتاج laboratory investigations، لازم أفهم الكونسبت بتاع laboratory investigations وأنا طالبها ليه، والمطلوب المعمل يعمل لي إيه، ولما أبعت للمعمل أبعت له التفاصيل بحيث إنه يبقى فاهم هو بيدور على إيه. ولما بتيجي بقى التحاليل بقراها إزاي. بس إحنا غالبا في اللي يهمنا في النهارده الCBC اللي هي البلاد بيكشر. طيب الاناتومي اوف ذا فارنكس، طبعا احنا خدنا الاناتومي في سنه تانية، بس ما خدناهوش بالطريقه اللي تفيدني اكلينيكيا. خدناه اناتومي، يعني اناتومي ببلاد سبلاي بريليشن، ممكن يفيدني في الجراحه، ممكن يفيدني في حاجات تانية كتير. ولكن في تشخيص السورثروت احنا بندي شويه سلايدز بسيطه كده نتعرف الاناتومي اوف ذا فارنكس اللي هو هيبقى فيه الامباكت اوف ذا ديزيز. شوفوا هنا مسكة التانج ديبريسور by the non-dominant hand, catch it from its middle, put over the anterior half of the tongue, don't push the tongue down, don't push the tongue down, and let the patient to say ah. 5 حاجات مهمين جدا تخليك تمسك التانج ديبريسور من غير ما تأذي العيان، ومن غير ما العيان يتضايق، ومن غير الطريقة اللي احنا بنعمل بيها. التانج ديبريسور you catch it from its middle, put over the anterior half of the tongue, don't push the tongue down, catch it by the non-dominant hand. طب ليه by the non-dominant hand؟ علشان لو في حاجة foreign body أو حاجة استخدم الدومينانت هاند في الاكستراكشن للفورين بودي. لكن لو ما فيش فورين بودي you are free to catch it by dominant or non-dominant hand. And let the patient to say ah. When the patient say ah, you see what is in front of you. This is a cheek, upper and lower lips, palate, tongue, oropharyngeal isthmus. It is a transitional plane. It is an imaginary plane transitional between the oral cavity and the pharynx. When we come so close, palatoglossal fold. It is a mucous membrane fold harboring palatoglossal muscle inside It starts from the palate to end in the tongue. And this is the tonsil. And this is the palatopharyngeal fold, starts from the palate to end in the lateral pharyngeal wall. And the tonsil lies in between the palatoglossal and palatopharyngeal folds. This is the soft palate, and this is uvula. This is the tongue. This is the oropharyngeal isthmus, which separate oral cavity from pharyngeal cavity. So, what is in front of you is the oral cavity. What's behind, what's hidden is the pharynx. What comes closer to elicit signs. How to elicit signs? During examination, you look for some important areas like this. So this is the vestibule of the mouth, which lies between the buccal surface and the teeth. And this is the mouth cavity prober, mesial to the teeth. It's not medial, mesial, yani inner to the teeth. This is the teeth. This is the vestibule of the mouth, and this is the mouth cavity proper. When we come close to elicit signs, so this is parotid papillae. This is a parotid papillae which secretion of the parotid secretion, saliva comes from here. So it is important. It's opposite the upper second molar. Important in what? What is the significance to diagnose this? If we have a red halo around it, we may call it complex spot. This is pathognomonic or diagnostic for measles. And if you milking a movement on the parotid by your hand, you will find the secretion inside the parotid comes from here. Even in pathological lesion inside the parotid, like blood, serous, or pus, or whatever, this comes from here. You can diagnose the parotid pathology from this area. So pharynx is laryngopharynx, starts from the epiglottis to the lower border of cricoid, and it's opposite 3, 4, and 5th, 4, 5th, and 6th cervical vertebrae, and from here to here, this is the oropharynx, and from here to here is the nasopharynx. So, this is the nasopharynx. Soft palate at rest lies here, but on swallowing, it comes here. So, upper border of the oropharynx is a contracted soft palate. Contracted soft palate separate oropharynx from nasopharynx. So the nasopharynx is a skull base, basis sphenoid, base occiput. Soft palate, when it contracts, at the level, it lies at horizontal with the level of hard palate. So this is the lower boundary. Lateral wall, it's like this. We find opening here, Stachian tube orifice, pharyngeal orifice of Stachian tube. Transmit air from the nose to the middle ear. In order to be open, it have to be active muscle ball, which is tensor and elevator palatini muscles that pull the opening to introduce air inside it. So the muscles have to have a solid anchorage, and here's mucous membranes have to be enriched. You see this hockey stick part of cartilage, which we call it tubal elevation, above and behind the Stachian tube orifice to give attachment of the muscles that open the Stachian tube. This is very important. So Stachian tube is not always open and not always closed. It opens only in swallowing and yawning. So this tubal elevation, when you look from here, from the nose, you cannot see this area. This is area, we call it pharyngeal recess, or fossa of Rosenmuller. This is very important. It is significant. The primary site of nasopharyngeal carcinoma starts here. So nasopharyngeal carcinoma is lately diagnosed due to late discovery. So a lesion here is hidden behind the tubal elevation in the fossa of Rosenmuller. So here also is a retropharyngeal lymph node, so it's very near. So retropharyngeal lymph nodes here may be involved very early in nasopharyngeal carcinoma. And this is the site of adenoids. So this is the anatomy of the nasopharynx. Now we are going to discuss Sorethroat. So when we start, what is Sorethroat? What is the definition of Sorethroat? Throat, what is the definition of throat? Throat, like she referred to, anterior half of the neck, anterior part of the neck. And what is the posterior part of the neck is the nape. So it is a Latin word. Throat means anterior part of the neck. What is inside the anterior part of the neck? Any pathology at any part of the anterior part of the neck may be reduced sore throat. Sore means discontinuity, means ulcer. Sore like beet sores, like mouth sores. Sores mean discontinuation of a surface. So sore throat means is not necessarily an ulcer present, but if you have an ulcer in your oral cavity, you feel a burning sensation. So burning sensation in anterior aspect of the neck means sore throat. This is a definition, the actual definition. So when the patient comes complaining like this, she have a pain on anterior aspect of the neck, and when we look at the pharynx by using the tongue depressor, by catching from its middle and so on, so we find, what do we find? It is congested, red. So what is the normal mucous membrane? You have to see normal mucous membrane before you say this is a congestion. Okay, so the normal mucous membrane of the oral cavity and pharynx is pale pink in color, wet in texture. Pale pink in color and wet in texture. When you compare it to the nasal mucous membrane is red, wet. And what is the difference? Why this is pale pink and this is red? Because here is a stratified squamous epithelium, and the blood supply underneath the mucosa is less than the blood supply of the nose. The nose have a rich blood supply, and the mucosa is only one layer, pseudostratified columnar ciliated with goblet cells. So it is very thin when compared to the pharyngeal or oral mucosa. So when you look at it, this appears pale pink in the pharynx and oral cavity, and then the nose appears red. Second slide, when we see a patient catching tissue, so we know the diagnosis, it is a viral. So when a patient complaining of sore throat, first of all, we know what sore throat is, and if she catch a tissue, so we have the etiology, and the etiology here is viral. So I know the etiology from the handkerchief. So this is important slide. 70% are viral, 15 to 30% of pharyngitis are bacterial, and the commonest bacteria is group A, beta hemolytic streptococcus. This is a very important slide. So how can you differentiate? So group A beta hemolytic streptococcus remains the most prominent pathogen requiring treatment. So the decision, is this pharyngitis attributed to group A beta hemolytic streptococcus or not? Why? Because group A beta hemolytic streptococcus, which was called Streptococcus pyogenes, has a relation with rheumatic fever, and we'll discuss it later. So every case, we have to know is it streptococcal or not. So we have other pathogens like Epstein-Barr virus, non-group A, influenza virus like the risk nowadays of influenza, H1N1, H2N5, or even corona, and HIV infection or gonorrhea. So the problem, can I use antibiotic in every case? This is what we are discussing right now. So first of all, sore throat, odynophagia, dysphagia and fever, erythema. So this is present in bacterial and viral. And so when you look at the patient, and hear the symptoms, group A streptococci, we have a dry mouth. But in viral, we have runny nose, conjunctivitis, hoarseness of voice. Even abdominal, nausea and vomiting and abdominal pain and gas, and here is diarrhea. Soft palate petechiae, small red spots on the soft palate, like donut lesions, beefy swollen red uvula, characteristic rash inside the mucous membrane, what we call it characteristic enanthems. And here is a scarlet fever, streptococcus also infection produce rash. Here characteristic exanthems for viral, other viruses like herpes, like measles and German measles have a characteristic rash over the body. Tonsillopharyngeal exudate is common in bacterial and less common in viral. So if the symptoms initially, we have also an important clinical tips. If the symptoms initially improved and then worsen, so we have secondary bacterial infection. So it starts viral for 2 to 3 days, and secondary bacterial infection made the symptoms more worse. It's happened on the 7th or 8th day. So what's the prodroma? We have a sore throat here, and after 4 days, this is the picture. So the patient comes to you without rash. So don't miss, especially in the season of exanthemata, don't miss that the symptoms of sore throat may be an initial symptom of something else. So prodroma appears in measles and German measles and chickenpox and smallpox. Smallpox is not present nowadays, but chickenpox is still present. So it started by sore throat, and then a few days later the rash and the vesicles will appear. So don't miss that. The patient may have eruption after the sore throat initiation. This is mumps. Also herpes. So we start our topic, pharyngitis. Pharyngitis, you have to put it in ranks, bacterial, viral, and fungal, and we'll discuss all of them. And this is a bacterial, and this is a viral, and this is a fungal. Also, we may have pharyngitis. It's not bacterial and not viral, but related to a systemic disease, and then added bacterial or viral over it. So if a patient comes to you every 2 weeks, every 3 weeks with pharyngitis and sore throat, please check the blood. It may be a granulocytosis or acute leukemia. It may be a skin disease like pemphigus and lichen planus. How come? It is a skin disease, but in these diseases, pemphigus and lichen planus, about 70% of patients have a pharyngeal symptoms. It comes to us before they went to the dermatologist. So a deficiency disease is not present nowadays, scurvy. Drug intoxication, so lead and mercury are present in cytotoxic drugs, chemotherapy. So after a course of chemotherapy or during the course, the patient may complain of sore throat. Also the patient who took antidepressant may complain of sore throat. And after that, there's something without actual etiology, actual known etiology, right? Recurrent abscess or Behçet disease. It may be an autoimmune Behçet disease, but we are not sure. So symptoms, it's very simple, general and local symptoms: fever, anorexia, headache, malaise, sore throat, dysphagia, referred otology, and fever. Here, when you say fever, don't see the actual fever, but here when you say fever in signs, you have to put the fever exactly after thermometer. So fever may reach 40, flushed face, local diffuse congestion of the pharynx, and enlarged lymph nodes. So streptococcal pharyngitis, group A streptococcal pharyngitis. Streptococcal have an X toxins. It resemble M protein, may produce complication, like we said, myocardial infarction, myocardial sarcolemmal antigen, and rheumatic fever due to it resembles the M protein present in the glomeruli and the valves, and so one synovial membranes. So streptococcal infection may lead to rheumatic fever due to antigen-antibody reaction. What is the significance of group A streptococcus? It causes also acute otitis media. It is over than 80 distinct M protein strains, can be diagnosed rapidly by rapid antigen detection test. Gas is likely to develop resistance, is a very sensitive organism. It can be treated by penicillin. So gas is the most common microorganism in bacterial pharyngitis. The delay or inadequacy of treatment can cause serious subsequent complications, particularly in children, due to rheumatic fever formation. So how come we give penicillin to the patient with pharyngitis and there is a resistance? And you say it's a very sensitive organism. How come? It's due to copathogens. If it comes alone, it is very sensitive. But usually, in about 1/3 of cases, it comes with co-pathogens, Haemophilus influenza and Moraxella catarrhalis, that distract the benzene ring of penicillin, so make the sensitive strep a very resistant strep. So, due to co-pathogens that come with the streptococci. So, the co-pathogen degrades the beta-lactamase ring, beta-lactam ring of penicillin, makes a sensitive strep act resistant. So the treatment detection also is a culture and sensitivity test is the criteria, the standard criteria of diagnosis, but it takes 2 to 3 days. Here, a rapid antigen detection test can detect it with 1 hour. So, streptococcal pharyngitis, we have to have a laboratory clue to see or to show the strep, and acute inflammation is an inflammation of the mucous membrane of the pharynx and lymphoid tissue. So any case of pharyngitis, is it strep or not? Okay, this is a very important question. When you have to differentiate, so if you have 10 cases comes to you, all of pharyngitis, and you want to know which children should be tested for strep, how should the children be tested? أعمل لهم إيه؟ and لو طلعوا positive هعمل إيه؟ طيب, patient with cough or rhinorrhea, this is viral, about 70% of cases. So the rest of the patient, 30% of cases, this will be subjected for either rapid antigen detection test or culture and sensitivity test. So, symptoms of pharyngitis that may pass unnoticed if the particle load of the organism is very low, or maybe if the particle load is very high, it may be produce toxic pharyngitis, ill toxic look, high fever, headache, and severe on swelling, and may affect the abdomen, vomiting and abdominal pain, and maybe streptococcosis in infant and toddler, low-grade fever, anorexia. Take care, this is a varieties of symptoms. So we said this, and we produce it in the first. So when we examine pharyngitis as signs, tonsil and pharynx, edema, petechiae, like we said before, exudate is more common here, not uncommon and viral, and palatal petechiae is also associated here. Group A beta streptococcus pharyngitis, it's from 5 to 15 years. Infectious mononucleosis, both of them produce palatal petechiae. But is bacterial, it's common from 5 to 15 years, and infectious mononucleosis in young adults and adolescents. So palatal petechiae in viral, Epstein-Barr, and strep. Here in children, 5 to 15 years, adolescent and young adults. So this is a complication, like we said, rheumatic fever, arthritis, carditis, chorea, glomerulonephritis, bacterial endocarditis. Rapid antigen detection test, like we said, in 1 hour. Throat culture, it's pathognomonic or criterion standard for diagnosis. Treatment, antibiotic, 14 days, penicillin and amoxicillin. And don't give lozenges that contain antibiotics. Local antibiotics encourage growth of monili. So lozenge containing local antiseptics is not preferred. So rest fluid analgesic and antibiotic penicillin 14 days. This is a treatment. Okay. Here, what is the rule of rheumatic fever? Like we said in ILOs, is the relation of rheumatic fever with streptococcal. Like we said, group A streptococcus never have resistance to penicillin. But when it become resistant, when there is co-pathogen present with it, like Haemophilus influenza and the Moraxella catarrhalis. Okay? How come I prevent rheumatic fever? Primary prevention means during the acute course. So here, primary prevention, I give it 14 days only. Treatment of tonsillitis or pharyngitis. In order to prevent rheumatic fever, you have to give antibiotics 14 days. Either benzosine penicillin, you give it once, or amoxicillin 50 milligram per kg, 14 days, or penicillin V, like we give it here, 250 milligram orally TDS 14. This is evidence rating, evidence-based 1B. So it is recommended. 14 days treatment to prevent rheumatic fever during the acute attack. Okay? And if we have allergy to penicillin, we can use azithromycin or azithromax, clarithromycin or clindamycin. And this is what you see, this is the dose. So if we have a recurrent rheumatic fever, if the patient already got rheumatic fever, and I want to prevent recurrence of rheumatic fever or prevent the recurrence of subacute bacterial endocarditis and the patient and the serious complications that may recur after that. So when we have an infection, you have to treat it over 10 days of penicillin. But if the patient cured and it's very okay, and right now, that's okay. You will prevent the primary, you prevent the rheumatic fever. But if the patient already have a rheumatic fever, you have to give him prophylaxis from recurrence of rheumatic fever. So prevention of the recurrent gasopharyngitis is the most effective method of preventing severe rheumatic heart disease. Here, gas does not have to be symptomatic to trigger a recurrence. It may come without symptoms. So the viral load in this type is not very large to produce sore throat and so and fever and so, but it recurs as asymptomatic infection. So prevention of recurrent rheumatic fever requires a continuous antibiotic prophylaxis. So if streptococcus comes again, so it will initiate the antigen-antibody reaction. So the patient may have no symptoms. If the patient is rheumatic and already have rheumatic attack before, in order to prevent recurrence, you have to give him long-acting penicillin in this dose. So rheumatic fever, duration of the last attack. If the patient have carditis, residual heart disease, you have to give him 10 years or until age 40. So when you have, how long you give him the prophylactic antibiotic? About 10 years or till the age of 40. With carditis, but no residual heart disease, no valve disease, I give him 10 years or until the age of 21, whichever is longer. If without carditis, 5 years only or until to the age of 21. And this is C. C is not a good evidence base. We have A, B, and C, okay? So this an optional, you can give it, okay? What is the drug you give it? Penicillin G, which is a long-acting penicillin. If it is below 27 kilos, say it 30 kilos, we give him half of the vial, 600,000 unit every 4 weeks. If it's more than 27 kilos, you can give him the vial, the whole vial, 1,200,000 every 4 weeks. This is A. evidence A. So it's very important. If the patient have recurrent fever, you have to give him penicillin G, benzosine penicillin, which is the long-acting penicillin. If it is below 27, give him half of the vial. If it is over the 27 in body weight, give him the whole vial. And for how long, like we said, until the age of 40, if we have a carditis and a residual lesion on the heart, or until the age of 21 if it's not. Okay? So, what is the meaning of antistreptolysin O-tetr? Antistreptolysin O-tetr does not diagnose a current infection. It diagnoses the antibodies against strep, which may reveal the past infection over the past 3 months. Okay? So it's valuable in identifying a preceding strep infection in a patient suspected of having a rheumatic fever. So it's not used for a diagnosis of a current lesion. Now we come for another disease caused also by strep, but here it's the exotoxin type producing. It produces exotoxin, so we have a characteristic rash. So it is pharyngitis with rash. So sudden fever, anorexia, headache, malaise, vomiting, rash. In the first 2 days of onset, the face will be flushed with circumoral pallor. This is a patient, flushed face. And then after 2 days, the rash discovered, cover the whole body. So it starts with sore throat, and after 2 days, this rash appears. So this is the tongue. So it is a problem, strawberry tongue, lymph node enlargement. This is the tonsils and scarlet fever. Same treatment, because it is the same organism. And why you don't give antitoxic serum? So the toxin is only producing rash. No other complication like carditis, nephritis, like in diphtheria. So we don't need antitoxic serum here. Like diphtheria here. You know, before 1920, a lot of cases, about 250,000 per year. But after 1920, it becomes only 1,000 cases per year. So the vaccination is very important, vaccination. And this is the man who discovered this vaccination. Thanks for him. And this Dr. Sheikh, who make a susceptibility test to see if the patient have to take it or not. You know Dr. Sheikh. And this is a diphtheria patient, very ill, very toxic. You know, we don't give details of diphtheria because it's not present right now, but you have to read it because if you want to know something about it. Comes now with the Vincent angina. What is a Vincent angina? It was called trench fever. Trench fever, why it's called trench fever? During the World War II, about a trench of soldiers, Britain soldiers in a trench was complaining of severe sore throat, and when the doctor came to him to see them, and he stepped down in the trench, he smelled a very bad odor. So he first of all think about anaerobic organisms because they live underground and they do not use mouth hygiene, so a lot of cares in the teeth, and anaerobic organism is very important in this situation. So this anaerobic organism produce halitosis. Halitosis means bad breath. And severe sore throat due to, you see this ulcer, so it is necrosis and this part of tissue is falling down, leaving a deep punched out ulcer. So Vincent angina is not a straightforward pharyngitis, but it is a gingivitis. We call it acute necrotizing ulcerative gingivitis due to bad hygiene and due to bad ventilation. And we take a swab and put it under microscope, he found 2 anaerobic organisms, Spirochaeta denticola and Fusiform bacilli. In order to honor them, they call it Spirochaeta borrelia vincenti. They named after Lieutenant Vincent and the Britain Army. So Mild general symptoms, mild fever, even no fever. So why we call it trench fever? This is not an actual fever. So the most important is so severe sore throat and marked halitosis. Sore throat also associated with odynophagia, means painful swallowing. Otalgia means pain in the ear. So Vincent angina, you have to see that, call it angina, severe pain, so severe sore throat. And we took it and we see the anaerobic organism. Antibiotic here must work on anaerobes, like penicillin and clindamycin. And they give hydrogen peroxide to alter the media of anaerobic, to give free oxygen, to alter the media, and they give him analgesic. We come to the infectious mononucleosis. It's caused by Epstein-Barr virus. This is a picture. You diagnose it tonsillitis and pharyngitis, but you order your patient to come back after 3 days. You find that the condition is worse, and the patient still complaining, even more complaint. So you have to change your mind. This is not a bacterial. We have to have it maybe a viral. Oh, so we have to do some test. Some test. This is a picture. It looks like bacterial. Looks like bacterial, but more edema, more severe. So, what is infectious mononucleosis caused by Epstein-Barr virus or cytomegalovirus? Rapid onset of fever and malaise and headache with constant fatigue. Why constant fatigue? Because it is a systemic disease. It affects the pharynx, it affects the liver, hepatosplenomegaly, it affects the spleen, it affects all the lymphoid tissue. It is a disease of the reticuloendothelial system all over the body. So we have generalized lymphadenopathy, hepatosplenomegaly, and why it causes constant fatigue. It may stay 1 to 2 months. So you have to diagnose and have to assure the patient that it is an infection, it's not other diagnosis. In order to say that, you have to keep in mind it is of rapid onset, constant fatigue, generalized lymphadenopathy, hepatosplenomegaly, 1 or 2 months. In order to be sure that it is Epstein-Barr virus, first of all, you have to request your investigation. So from the name, I have to shake a blood picture to see the monocytes. It's mononucleosis means we have a monocytosis. Also, it is a virus, so lymphocytosis with atypical lymphocytes. It is an aggressive virus producing more lymphocytosis. Keep in mind the COVID-19 produce lymphopenia. So not all viruses produce lymphocytosis. So Epstein-Barr virus produce lymphocytosis, not lymphopenia. And aggressive, so it may you may have atypical lymphocytes due to rapid processing of lymphocytes. So white blood cell count show monocytosis. So you have, when you have to say monocytosis, you have to know the normal reference or normal figure. What is a normal figure? What of monocytes in the white blood cells? It's about 2 to 8%, sometimes 2 to 10% of the white blood cells. So if you find that the number is 7 or 6, so you may see it is of normal range. But keep in mind, you don't have the figure of yesterday or the figure of a few days before. It was 2 or 3. And now it is 7 or 8. So it increases. So we have monocytosis. So don't say within normal range unless you have the previous figure. So if you don't have a previous figure, you have to request serial diagnosis. You may repeat the test after 2 to 3 days to see if it is raising or not. This is about monocytosis. What about heterophile antibodies? We know ball panel test and monospot test. Both are agglutination tests. You take the patient blood and centrifuge it to take the serum and to put RBCs with the serum. If the RBCs agglutinates, so it is an agglutination test. If it agglutinates, it will be positive. So you have the heterophile antibody. So what is the difference between two tests? Ball bundle test, the RBC source is a sheep. Monospot test, the RBC source is horse. So the same concept, it is an agglutination test. So like we see, type monospot test, infectious mononucleosis, 95% sensitive in children, 60% sensitive in infants. But we have false positive, toxoplasmosis, rubella, and leukemias, and false negative, like you know, it's too early, or young children, or elderly patient. So, still there is a debate, still I cannot reach a final diagnosis. So the last step in diagnosis to know the immunoglobulin, if Epstein-Barr virus, actually for Epstein-Barr virus, to know the titer of the antibodies. So in order to know the immunoglobulin, we have to know the antigen. The Epstein-Barr virus has 3 types of antigen: viral capsid antigen, early antigen, and nuclear antigen. So you request immunoglobulin M or immunoglobulin G. M for current lesion, G for past lesion. So in order to diagnose a current lesion, you have to request immunoglobulin M of viral capsid antigen of Epstein-Barr virus. So when you request immunoglobulin M of viral capsid antigen of Epstein-Barr virus, you are very decisive in requesting the lab test from the lab. So if it is positive, is that very okay that it is sure infectious mononucleosis. Treatment, no problem. Rest, analgesic, no specific treatment. Antibiotic may produce rash like ampicillin, so avoid ampicillins. Monelias, it's fungal infection of the oral cavity like this may produce sore throat. This is the oral thrush, and this is Monelia. You have to take and to put him, take a swab and take him under microscope. You see the fungus hyphae, and give him local miconazole or nystatin. And thank you very much.